Hi, I'm Dr. John McAllister. We're going to discuss anterior cruciate ligament reconstruction. Everything we discuss is also available at St. Peter's Bone and Joint website. The anterior cruciate ligament is a major ligamentous structure in the knee. The ligaments are what connect bones together, and tendons connect muscles to bones, ligaments connect bones to bone. So I have a model of a knee here. There's collateral ligaments that are easier to see, I think, and this is the medial collateral and the fibular collateral, lateral collateral ligament. If we move the kneecap out of the way, we can see inside the knee, and this ligament that's right in the front is the anterior cruciate ligament, and there's actually a ligament behind it called the posterior cruciate ligament. Often people tear their anterior cruciate ligament in sports, so the running or twisting injury, they often hear a pop. It can be a collision that causes the injury. It's about 3 times more common in women than men for probably a number of reasons, but it's certainly become a very common and unfortunate injury for an athlete. We deal with this often, and we can get people back in the game and back to their sport in a reasonable amount of time with some very modern techniques now. The ACL, unfortunately, when it tears, it's in the middle of the knee, and it doesn't just magically go back together again and get tight and heal back. So if you've torn your anterior cruciate ligament, what that allows is the tibia to come too far forward relative to the femur. So the ACL is the ligament that prevents this tibia from sliding too far forward. And where that really comes into play is when we plant our foot and want to pivot. So with people that don't have an ACL or have torn their ACL can usually walk and get around okay, but they may have a hard time rapidly changing directions. And certainly any kind of sports such as soccer or football, basketball are very difficult without an anterior cruciate ligament, and really not particularly safe without an ACL. Over time, if you don't have an anterior cruciate ligament, that extra movement or play in your knee will begin to damage the other structures, such as the cartilage that covers the bones and these meniscus cartilages here. So typically, if you're a reasonably athletic person, you've torn your anterior cruciate ligament, you likely would like to have that replaced. Let me try that again. You'll likely want that replaced. What we do is actually rebuild the ligament. Nobody's been able to sew the ends of the ligament back together again and make that work. So we have to borrow something from somewhere and put it in there to make a new ligament. The classic operation involved using a piece of the tendon that connects the kneecap to the shin bone, and I've done many of those and still can. We take that out with a little bit of bone here and here and remove that and then put that in the knee. The problem with that is that a lot of people will get anterior knee pain, not a lot, maybe 1 or 2%, but if you're that person, it's usually unfortunate and there's not much we can do about it. We have more often now I use a hamstring tendon, which actually comes from the back of the leg, but through a little incision right here, usually about that long, I can harvest a nice long piece of tendon, don't ask me how. And then we fold it over 4 times and make a nice thick graft that we install in the knee. All the work inside the joint is done arthroscopically, so we don't have to open it up like this. We look inside with a little camera and a light, and we have little special tools designed by geniuses to be used. I didn't design them. But the anterior cruciate ligament, we can actually see where it's attached on the tibia and up on the femur in the back over here, and we can target that with a little guide and put a little pin in the center of that ligament in the bone. And then we enlarge the opening with a little drill or called a reamer and make a little tunnel. And I make sockets so we actually do it from inside the knee, so we don't have to drill in from outside. That makes the surgery less painful. And then into these sockets we can bring this little graft that we have up in and attach it in both of these sockets. We have a nice way of tightening and tensioning it up and holding it in the sockets so that if you make a fresh tunnel in a bone, put a tendon down in it, the tendon and bone are going to heal together because tendon's normally attached to a bone. In this case, since we're attaching it to a bone at both ends, we're turning a tendon into a ligament. And that can be done again with a patellar tendon. It can be done with a hamstring tendon, which is my typical preferred operation now. We can also use allograft, where we take a tendon from somebody that's passed away, a donor, and put that in. There may be a little bit of risk of disease transmission, although they test for everything. There may also be a little more slow incorporation of the tendon into the bone. We think that if you use your own stuff, it heals more quickly into the bone and probably provides a better graft long term. The advantage of using somebody else's is it's a little less painful, and probably for an old guy like me, I might use an allograft because I'm not as active, but for young people that are still playing sports, we think that using your own tendon will make you less likely to re-tear your anterior cruciate ligament. So since we talked about re-tearing it, there are risks of any operation. The risk of a re-tear of an ACL depends really on what you go back to doing and how soon you do it. Probably in the order of 7% can get another injury, especially if the girls are going back to soccer or boys are playing football. Those certainly are associated with a higher risk of re-injury. I like people to wait as close to a year as they can. The NFL will typically make a football player wait 8 or 9 months before he can resume football. If you go back at 4 to 6 months, and you may find the doctor that tells you it's okay, it is okay, except that you have a much higher risk of re-injury. So you should at least be aware of that. If you can delay return to really aggressive sports for a season, it's very helpful. I think safer in the long term. There's other things that can be injured at the time of an anterior cruciate ligament tear. There may be some cartilage damage. There could be a meniscus tear. We try to address those things at the time of arthroscopic surgery. Typically, the reconstruction is delayed for about 4 weeks, give or take a little bit, but if we found that if we do the surgery very rapidly, early, in the first day or two after injury, there's a higher risk of getting scar tissue and having stiffness in the knee. So by cooling the knee off and getting the movement back, you actually decrease your risk of one complication, which is stiffness. I usually have people go to physical therapy for a visit or two prior to anterior cruciate ligament reconstruction, and then you will typically start your therapy on the 3rd day after the surgery. I like to use a CPM machine for about 2 weeks. It's just a machine that moves your knee. A lot of people think it feels good to use that. Lots of ice is very helpful to decrease swelling. Most of the time you can put your weight on the knee from the first day. If I do a meniscal repair where I put stitches in the cartilage inside the knee, we've talked about that a little bit, but this is the cartilage here. If I put stitches in that, I'd like you to not bear weight, use crutches for 2 weeks to allow a little early time for that cartilage to begin to heal, and then we can start bearing weight. It's an outpatient procedure. Takes me about a couple hours, give or take a little bit, depends on what else I have to work on in the knee. But we do about 2 hours surgery, outpatient, then you go home, you prop it up, keep ice on it, start that CPM machine the next day, go to therapy in a couple days, and I'll change the bandage. I use a hinged knee brace for 6 weeks. That helps prevent rotational stress across the knee. But actually bearing weight and just normal walking, the way we attach it, it's sturdy enough to hold up to that, and we'll maintain that graft while it heals into the bone tunnels. After the graft's healed into the tunnels, there's a period of time where it matures, gets stronger, and new blood vessels grow in, and that's the problem with starting sports too soon, and why we like you to wait a little longer to go back to really aggressive activities. But you can run at 3 months after surgery and begin doing a little more sport-specific conditioning around 4.5 months after the operation. So if you have specific questions, you'll have an opportunity to discuss that in the office. I hope this has been helpful.